My name's Philip Stricker, and over the last 10 years I've been working on developing a new form of treatment, a minimally invasive new form of treatment for prostate cancer. With now over 600 cases treated and over 20 international publications, I'm pleased to say that this treatment is here to stay. So why is this treatment necessary when there are so many other established treatments for prostate cancer, such as surgery and radiotherapy? The reason is because the other treatments, such as surgery and radiotherapy, have significant side effects, and we've begun to learn much better now how dangerous individual cancers are and how we can select less dangerous cancers for less invasive treatments with less side effects. And it's for that reason that I worked over 10 years ago on developing this new treatment with some colleagues overseas. The reason it's developed is because imaging has improved and we can now see the cancers with MRI and PSMA PET scan, and we're better able to deliver energy sources to the prostate in a targeted way, thus minimising the side effects of erection problems and incontinence. So let me explain what focal therapy means. What focal therapy means is that you treat only a section of the prostate instead of the whole prostate in a highly select group of patients in which it's appropriate to do so, minimising side effects. I suppose it's a bit like lumpectomy in breast cancer, which of course developed 20 to 30 years ago, and certainly we seem to be a little behind our female colleagues in this area. Having said that, there is a very strong movement internationally now to popularise and move these treatments from experimental to mainstream medicine. And the reason for this is because we now have intermediate to longer term data. We now have registries covering many sections of the world recording the data, and we even have international randomised controlled trials commencing in this area now. I've been proud to be a part of the development of this treatment, and now having treated over 600 patients and with many publications looking at the data from this group, I'm delighted to say that I feel now comfortable with offering this to select patients. I have to admit that there was a learning curve of about 20 to 30 patients where we improved the technique and the selection of patients, but after we'd overcome that learning curve, we've been delighted with the outcomes. So what are the outcomes? We use this treatment in two groups of patients. One group is where they have never had any previous treatment, such as radiotherapy, and the other group is where radiotherapy has failed. Let me address the first one. In the group of people who walk into my office with a small localised Gleason 7 cancer, which is a relatively non-aggressive tumour, which is localised to a certain area of the prostate, which we feel confident of based on the imaging and the biopsy information, this group of people seems to be a suitable group of people to target for this treatment. In our most recent publication in the British Journal of Urology, the chance of curing the cancer, or as we say, clearing the cancer from the infield, is about 97% on the latest results. The chance that the cancer will come back in another part of the prostate over the next 5 years is approximately 20%. Even if it does come back at that stage, we have the opportunity of redoing the Nanoknife or falling back on traditional therapies. We have no incontinence and minimal impotence and no rectal damage and no major safety issues. It is really an effective and safe treatment in the right patient cohort. So just to be clear, the right patient cohort that we've learnt after many years is a localised Gleason 7 cancer, preferably 3+4, confirmed by MRI, possibly PSMA PET scanning, and template transperineal biopsy. Patients who are suitable for this treatment need to accept that there are no long-term data yet, but there is intermediate-term data. They need to understand that this is not a standard of care yet, that surgery and radiotherapy or brachytherapy are the standard of care still, but they do need to understand that it's safe, and they do need to understand that there is a need for monitoring after this treatment. And they also need to understand that all other treatments are available to them if this fails. It can either be repeated, or surgery or radiotherapy can be offered if it fails down the track. And we've been pleased to report in one of our papers that even surgery appears to cure over 90% of these people, even if the Nanoknife ultimately fails. If you are suitable for this treatment, then you can expect to have a day surgery procedure taking less than an hour. You will recover to normal activities almost immediately. The safety has been shown to be extremely high. The chance of curing the cancer, or clearing the primary cancer as we call it, is 97%. Your chance of getting or developing impotence is less than 10%, probably closer to 5%. And the chance of becoming incontinent is almost zero. Major complications have not been a feature of any of over 600 patients we've treated. If you come to me with a new diagnosis of prostate cancer, then I'll discuss with you all the treatment options, including surgery, radiotherapy, active surveillance, or some of the newer treatments such as MR-Linac machine treatment, in addition to focal therapy. I'll try and give you a balanced view of the pros and cons of each one, and because I have significant experience in all of these treatments, I can give you my personal experience of which one is most likely to benefit you or be suitable for you. I'll also walk you through the results that we have currently, not only from the surgery and radiotherapy point of view, but also from the focal therapy point of view with the Nanoknife. You may ask, why the Nanoknife and not other forms of energy in focal therapy? The reason why I chose Nanoknife is because the Nanoknife uses a form of electricity called irreversible electroporation, which is non-thermal. So it doesn't require heat or cold to kill the cancer off. The benefit of that is that it can potentially protect adjacent structures like nerves and tubes, whereas the thermal ones, such as HIFU, laser, and cryotherapy, do not protect those structures. So I went with that, and I've been pleased that I went with that technology, as it's proven to be not only safe, but it also seems to protect adjacent structures, and it also can be used in any part of the prostate, and it also can be used in parts of the prostate that the thermal energies can't be used in. In summary, the reason why I chose Nanoknife therapy, or correctly called irreversible electroporation, is for its safety profile, for the results that now are well published from our unit, from the cancer outcomes, and from the potential salvage options which are all open in the future if it doesn't work. So where to from here? I'm currently teaching many urologists across the United States at some of the most prestigious institutions in the world, in addition to training units in Europe and in addition to training Australians and New Zealand urologists. At the current time, the PRESERVE trial in the United States, run by the FDA, has completed accrual and looks to have results equal to our results. The randomised trial in Stockholm between surgery and focal therapy with the Nanoknife has commenced accrual. The National Institute of Clinical Excellence in England has moved this treatment from an experimental treatment to a mainstream treatment with appropriate informed consent. And units are combining to keep accurate registries of all the data worldwide. All this will come together and eventually make this an accepted mainstream treatment for certain patients with prostate cancer. So from the early days in 2013, when I commenced this therapy, to the current time, having now treated over 600 patients with over 20 international publications, with supervising international randomised trials and the FDA PRESERVE trial, I feel that we can now offer a form of treatment in selected patients, that is focal nanoknife therapy, to avoid some of the serious side effects of surgery and radiotherapy, such as incontinence and impotence, and cure the vast majority of them safely and effectively.